Good evening, everyone. I am Janvi, and I warmly welcome you all on behalf of Find Utsav Lentinos to today's webinar on single visit versus multiple visit endodontics. Please keep your mics on mute and feel free to drop questions in the chat. We will take them up during the Q&A session. The session has been recorded. It's my pleasure to introduce our guest speaker, Dr. Aishwarya Arya, MDS Consulting Endodontics and the founder of Root Crown Foundation. With her expertise in aesthetic and conservative dentistry, we are thrilled to have her guide us through this important topic. Over to you, ma'am.
Good evening, everyone. It's my pleasure to be a part of this webinar today. So we'll be moving quickly to the one of the most important and most debated topic, that is single visit versus multiple visits endodontics. Okay. So I hope my voice is pretty clear when it comes
Yes, ma'am.
to. Okay, fine. Yeah.
Yes, ma'am.
So, when it comes to root canal treatment, right? The first thing, whether we have to start with a single visit or a multiple visit endodontics, will always begin from the time of diagnosis. Okay. So, the moment a patient comes in your chair and you start moving towards the treatment of a root canal after doing a diagnosis, starting from the signs, the symptoms, the radiographic interpretations, as well as what is the previous history of the patient, and also how is the response of the patient to any previous history of any root canal treatment or any kind of dental treatment. That all in combination helps us to make us realize what kind of, whether it will be a single or a multiple visit endodontics. Okay. So, moving to the introduction part, the main objective of performing a root canal therapy is only one thing, that is to eliminate all the bacteria as well as the byproducts of the bacteria from the infected root canal system along with the inflamed pulp tissue. Okay. So, if the bacteria are removed to levels that are undetectable by bacteriological methods to use today, then an extremely high success rate in the resolution of apical periodontitis can be expected. Okay, so this basically means that our main objective will always be to clean the canal out of all the bacteria which is present in the canal. Once that is clear, once that has been eliminated to the best of our ability, the patient will never have pain, and the debate regarding the single and the multiple visits of root canal treatments is always going to be compensated. Okay, so we have a few principles of endodontic treatment. So why am I talking about the principles when it comes to single and multiple visits? Is because the debate itself is going to get over if we are going to follow all the principles of an endodontic treatment. Okay, so we have to use an aseptic technique. That is the first thing. The second is cleaning the canals thoroughly and mechanically with the aid of chemical agents. Okay, so when you do a biomechanical preparation, along with that we do irrigation, right? So why do we do that? Because when we're doing a biomechanical preparation, we are removing all the pulpal remnants, the bacteria, the debris, the all the necrotic tissue from the pulp canal mechanically, right? But in adjoint to that, we need chemical agents. That is why we have the irrigation protocols in order to help us to eliminate all the bacteria from the root canal system. Okay. Next is shaping the canal, right? Like obviously mentioned that before the ease of obturation. Then why do we do an obturation? Because we need a tight seal of the root canal so that they are not reinfected. And then obviously the most important thing here is proper restoration of the tooth to prevent any kind of coronal leakage which can future cause a bacterial reinfection. Okay, so see, it is very important to understand the prognosis of your treatment. It's not always you do a root canal and the case finishes. No, it's always about how and when the tooth is going to last into the oral cavity, and that begins from the first up to the last step of your root canal. The apical sealing as well as the apical construction are very significant when it comes to prognosis of the treatment, whether you do a single or a multiple visit. So next we'll come to what is the role of first appointment. Okay, so now here, if you ask me, I am more of a person who is inclined towards doing multiple visit root canal treatment, irrespective of the time that would be taken. Okay, reason being that there are various clinical scenarios which demand multiple root canal treatment cases. Also, there has been literature debate on whether the success of single visit or a multiple visit was taken into consideration, and many studies have also reported that there were not significant difference in the post-operative pain, but the success rate for a multiple visit root canal treatment was always higher. Right now, I will be justifying to what I will be sharing in my further slides. So, when it comes to the multiple visit root canal treatment, you should always understand that the first appointment is very important, because in most of the cases, either the patient has come to you because of any pain, swelling, or the patient might have turned to you because of aesthetic reason or for any trauma case. Okay, so, when it comes to the role of first appointment, the scientifically documented procedure for best results in canal disinfection is always based on complete mechanical debridement, irrigation, so as to make the canal completely antibacterial in nature. And this is going to in turn help us in eliminating the bacteria with 40 to 60% of the tooth. Okay, so, and then we have the role of intracanal maintenance. So, dressing the canal for 1 week with calcium hydroxide has always shown to be a better result. So, in this case, it can also be any other intracanal medicament, for example, triple antibiotic paste, that depends upon the clinical scenario. By extrapolation, the regimen, including calcium hydroxide dressing between the appointments, should be at a very higher rate, which helps in healing and adding to multiple visit endodontics. Now, when we come to single visit endodontics, because of the use of higher technologies, the magnification, rubber dam, apex locator, and all the different kinds of heat treatment nickel titanium files, they have helped us increase the success towards single visit endodontics also. Endodontics, therefore, can be completed in a single visit. Now, we have two important controversies which relate to single visit. The first is the efficacy of a single visit appointment therapy, and the second is the determination of the apical terminus of the root canal. Now, the apical terminus of the root canal, I'm talking about the apical foramen, I'm talking about the apical constriction, the major and the minor diameter, right? So what happens is, you must have noticed that the moment you place your first file in the canal, okay, patient will have pain. Now, this pain can happen because of two important reasons. Either there it's a vital tooth, or your local anesthesia is not working, or you have gone beyond the apical foramen. That is where we use the apex locator, which helps us to determine what will be our apical constriction, what is going to be the actual working length of the canal, right? So what happens, what I'm talking about here is, the moment you explorate or you exploit the apical constriction, even though you have done a wonderful obturation, you have used all your best ability to use your intracanal medicaments, the activation of the irrigation, all your devices, your loops, everything. But if you're violating your apical constriction, then there can be post-operative pain. For second thing, if you are violating your apical constriction, you might extrude your sodium hypochlorite beyond the apical foramen. So what happens is, stability in single visit plays a very important role, because what happens in a single visit, you have already sealed the canal, right? And once you have already seen the canal, then the patient comes back with the post-operative pain. Even though your obturation looks perfect, you will not know why you are still into the dilemma of patient is having pain, right? So that it can be because you might have extruded the sodium hypochlorite beyond the canal, which might not be visible in your radiograph after your post-operative treatment, right? Or you might have violated the apical construction. So the single visit versus multiple visit has been subjected to a long-standing debate in the dental community. So this is Euler's criteria, which helps us to understand where we are supposed to do a single visit. The first is positive patient acceptance of a single visit endodontic therapy. The second is sufficient available time for the complete procedure properly. Now, this is very important. If you have a line of number of lined up patients and you cannot go for a single visit, you need to follow all the protocols, which correlates to my first slide, which I had already mentioned, that all the protocols of an endodontic treatment has to be followed, whether it is a single or a multiple visit endodontics. The third is obviously absent of any acute symptoms. The fourth is absent of any anatomical obstacles or procedural errors. Okay, so the single visit, most importantly, is very significant in case of vital pulp therapy and not in case of non-vital, because in non-vital already the tooth is necrosed, having a lot amount of pulpal remnants, the gram-negative bacteria, which needs an extra sitting, it needs an intracanal medicament dressing. Okay, fine. Now, what are the disadvantages when it comes to single visit? It may involve time restraint. It can cause fatigue to both the patient as well as the clinician. So, a lot of amount of we know the anatomical variations when it comes to root canal therapies. There can be calcified canals, there can be weeping canals, there can be severe curvatures, right? So, which will require more amount of time as well as patience for the clinician and the patient. And I always believe that we should respect our body and give it time for healing. You should understand that a tooth to undergo a RCT or for the bacteria to invade into the root canal system takes years and years of together, right? It doesn't happen that once the bacteria entered the tooth and it's gone for a pulpal inflammation. It doesn't happen like that. When it has taken such a long time for the bacteria to act upon the root canal system, then why don't we also give it some time to heal? Why don't we respect the normal body defense mechanism in order to give time for the tooth to also heal in its own way and in its own time? So you cannot go ahead with a single visit only because the patient is demanding. You have to act according to the science, because tomorrow when the patient is going to have pain after a single visit endodontics, the patient is only going to always blame the clinician. Ki, I came to the best dentist and I got my best treatment done, but my whole point of reducing the pain has not yet been taken care of. So therefore we need to be very very importantly understand which case needs a single visit and which needs a multiple visit. So the last is no easy access to the apical canal if there is any case of flare up. So you know what is flare up? So basically the flare up is basically un unexpected symptoms that arrive after a root canal treatment inter appointment cases. So in those cases, patient might turn up with pain, and if you finish the case, then you need to remove the entire obturating material from the canal, and then you need to clean it, irrigate it right. So why don't we give one extra dressing and we give it time for it to heal? Definitely, we can carry out single visit in cases of acute, in cases of vital tooth therapy, where we see that there is no periapical infection, there is no PDL whitening, and there is no resorption cases happening. So, in those cases, definitely single visit can be added. Fine. So, then we move to the next part. So no opportunity to place an intracanal disinfectant, like I told you, in single visit. If there is any exudation, pus discharge, it is very difficult to control in the same visit. and also it eliminates some of the controls which is available in the multi-visit treatment. For example, checking our biomechanical preparation, whether it is proper or not, or whether how the patient is feeling after the root canal treatment, how is the response of the tooth. So many factors has to be considered when it comes to single visit endodontics. So we have a few indications of SVE, that is single visit. The first is obviously a physically disabled patient, because the patient cannot travel to your clinic a number of times. The next would be patient who is requiring for sedation. Those are mostly pediatric patients, right? Because they are not able to sit on the dental chair for a very long time. The third would be a fractured anterior case, because obviously they are aesthetically involved. So we want to finish off the root canal in a single visit and then go ahead with the composite buildup and the aesthetic buildup, because here in these cases the tooth are vital and the patient is more concerned about their aesthetics rather than the root canal treatment. And definitely a vital pulp exposure due to any caries or trauma which are symptomatic pulpitis. So here we need a intentional root canal treatment in order to give a crown. Teeth with are requiring immediate post and core placement, and then where a temporary seal cannot be placed within the appointments. So it is very important that you understand that where you need an intracanal dressing, and also you should understand that will you be able to place a temporary seal material properly in between the appointment, because I'm going to talk about a few tips related to multi-visit and placing your temporary cavit, which we call often in the appointment room, so obviously the contraindication when the patient we feel that there are no dry canals and there is a pus discharge and the sealing of the obturation has to be compromised. There is not sufficient time available to complete the procedure, and also if there is any kind of increased stress to the TMJ of the musculature or increased physiological stress to patients or clinicians. Now, look at this scenario. Can you see here what is happening to the intracanal or to the periapical infection which is present there? It is almost causing a resorption. It is a severely curved canal, right? And we also see that this tooth really needs an intracanal medicament. There is an abscess, there's a pus discharge, and we need to take care. And this cannot go for a single visit. We are not magicians. We should understand that we are doctors and we should respect the science behind the work that we do, right? So, definitely, when we take antibiotics for any systemic problem, the dosage of antibiotic is never one, right? It always comes in combination, whether it comes in three appointments, 3 tablets, whether it comes in 4 tablets, it depends. So why is that, right? Why is that? That's because the entire system that it needs, it is very important, it needs the number of visits that has to happen. Okay, so that is the reason that intracanal medicament is very significant and multiple visits endodontics comes into role, right? Okay, so these are the following indications when it comes to multiple visit endodontics. The first is allow time for lessening of symptoms such as pain. The second is tooth with doubtful prognosis. The third is positive effect of the intracanal medicament, reduction of the postoperative pain, and obviously the patient or doctor time constraint. Now, when no bacteria recovered from the root canal stage and the filling stage, healing of the periodontitis uneventful and independent of the quality of the root canal treatment. Now, what I'm trying to tell you here is shaping and cleaning or the number of sessions of the root canal medicament does not practically influence the success. The whole story comes down to how effective is your treatment in helping in eliminating the bacterial remnants, the byproducts from the canal. Success of endodontic therapy will always depend upon how effective your procedure is rendering in canal bacteria free. So, therefore, the entire debate whether it should be a single, a multiple, or a two visit endodontic has to be stopped. It has to depend upon whether the number of visits, if you're taking, has helped us in eliminating the amount of bacteria from the canal. If it has helped us, and if from a single to a multiple visit is helping more as compared to a single visit, and obviously depending upon the clinical situation, we should go for a multi visit, even though you are planning to do only two visits. Okay. So the most important common problem with the inter-appointment treatment is always post-operative pain. Single visit treatment causes more post-operative discomfort and flare-up because see what happens is there is bacteria and necrotic tissue inside the canal. The moment you have done a BMP or placed an intracanal medicament, you've used your irrigation protocols, you try to clean it, right? Now place intracanal medicament and give it time for it to heal so that in the next appointment you come back with a better resolution and a better understanding of how your science and how your treatment is helping the patient, which will help us to reduce the rate of flare-ups in future. So even Fox and co-workers have found that 7% of the single visit reported with pain within 24 hours, whereas the pain really came down in 90% of the teeth where there were multiple visits. So there are a lot of studies, if you can see here, first for the why the oleate that the incident of post-operative pain and healing was same in single as well as multiple visits, whereas Kefi said also the same that there was no significant difference. But yes, when it comes to the anterior teeth, there was low incidence of post-operative pain when it came to multiple visits. Mulan et al. Also said that there was no statistically significant difference, but yes, when it treated necrotic pulp, always can be treated in 3 appointments. So, whereas that was contraindicated by Ronnie, he said that higher frequency of post-operative pain was seen in multi-visit. Now, this can be attributed to a lot of other factors, which I'll be discussing. Most importantly, clinically, what happens that why multi-visit also can cause post-operative more pain, and we have Albesh et al. Who also said that higher incidence of obturation pain was in multiple visit as compared to single visit. So, what are the different disadvantages now we want to talk about multiple visit? The first and most important thing is inter-appointment contamination. Now, this can happen very significantly if your intracanal medicament is not placed properly. There are leaky margins. There can be flare-ups because of lack of temporary seal. Prolonged period of time, patient fatigue. The patient has to always come back to the clinic. Obviously operator fatigue, then inability to provide any aesthetic kind of a restoration, obviously for a traumatic tooth, because patient is more concerned about aesthetics, and the tooth also may be susceptible to reinfection because if there is any loss of cavities. Okay, so now we'll move to very important part of my lecture, that is 10 important tips when it comes to multiple visit root canal treatment. The first and foremost will be oral hygiene practice. You need to understand that the moment patient has come and sat in your chair and the moment you have started thinking towards a prognosis of your treatment protocol, you have to keep in mind how is the oral hygiene practice of the patient. If you feel that the patient has a lot of calculus, lot of stains, patient is not maintaining his oral hygiene properly, always move towards a multi-visit endodontic treatment. Never plan for a single visit because the oral hygiene practice is less in the patient and the patient's immunity is down. Therefore, we need to go for a multi-visit. The second is proper root canal treatment protocols. This is very important. If you feel that you are not able to do a proper biomechanical preparation, you have not followed all the rules of irrigation protocols, the activation, the rubber dam seal, then definitely you can take one more appointment in order to see how the body is healing and then go for a multi-visit. The third is condition of the temporary material in the next visit. When the patient comes back with you in the second visit, if you see that there is a dislodge of the temporary material and there is a weeping canal, then definitely it might require one more sitting in order to place a calcium hydroxide and give it a dry canal before you actually go ahead with your obturation. Role of antibiotics plays a very important role. You need to give a set of antibiotics, but not all cases of root canal treatment needs antibiotics. We also need to understand this, that root canal treatments do not need multiple visits along with role of antibiotics. Only in cases where you feel that the tissue is necrosed or there is an abscess, the role of antibiotics plays an important role. There has been reported cases of contamination from saliva. So when we are doing a multi-visit root canal treatment, the rubber dam isolation becomes very important so that there is no contamination from the patient's saliva as well. Because there have been so many studies stating that also the bacteria from the saliva transfers into the root canal and can lead to causing of reinfection during our multi-visit appointments. How effectively have you placed your intracanal medicament also plays a very significant role when it comes to how you're going to place. So always the tip here is when you have placed your calcium hydroxide, take a radiograph to understand whether your calcium hydroxide has actually reached the periapical status, because that's where we need the maximum decontamination of the bacteria. How you place your temporary filling material, like I told, is very important. So the tip here is do not place a cotton roll. Always use a cavit to close the orifices. First, place your paper points inside the canals, then place a cavit, and then place your temporary cavit material. Do not place a Teflon tape and then go ahead with the temporary cavit material. Use a Teflon tape. Do not use cotton. The reason being, the cotton has fibers. The fibers are the channels from where there can be leaky margins from the contamination of the saliva or any food products which the patient is going to take in between the appointments. You understand? These cotton fibers you might not be able to see, but even if small cotton fibers, like you have seen, right, how the cotton is, the fibers which are going to get entangled with your cavit and seal, the moment the patient eats anything, these are nano leakage channels which act as pathways towards causing a reinfection even though you have done a proper root canal treatment. Okay, so always follow and place a cavit which are not hanging outside your canal chamber and will not cause a reinfection. So yeah, de-occlusion of your teeth is important, but again, this doesn't mean that you start de-occluding all the teeth. This is also not important because we are moving towards now more conservative practice. We are moving now towards more biomimetic practice. We are moving now towards not giving crowns where it is not required, right? We need to preserve the pericervical dentine. That is very important. So not all teeth needs crowns. Okay, we can use ribbon fibers. We can use so many other materials also to give the strength back when it is needed. We can go for endocrowns. But in teeth where you feel that there is a periapical infection, there is periodontitis, there is PDL widening, in those cases, we don't want the patient to come back with pain in multiple visits. So we need to do a de-occlusion of the teeth in the first appointment. Systemic condition of the patient also plays an important role. To understand if the patient's overall systemic condition is compromised, then we might need a multi-visit, and we need the antibiotics might be adjuvant in order to reduce the infection because the immunity of the patient might be low. And yes, the time between the inter appointments. So many times it happens that the patient has missed the appointment, right? In those cases, also the rules of multi visit is very important. How you seal, give a temporary seal to the tooth, okay? How you have placed your intracanal medicament, and whether the intracanal medicament has been, seen with an X-ray after placing it, and how the temporary material has been placed, whether you have done your biomechanical preparation and irrigation properly, because sometimes because of n number of reasons the patient also might miss the appointment. So we need to be very very careful when it comes to multi-visit. So I would like to conclude by saying that even though there is a big debate going on, and yesterday I had posted regarding multi-visit as well as single visit, and there were almost 100 people who have replied, and there was a very thin percentage gap between a single and a multiple visit, where this debate has always been into picture. Our picture is that the tooth should after a week. And for that, I believe that you should give one more chance for the healing to happen naturally, and then go ahead with the obturation, giving much more higher results for a multi-visit endodontics. So thank you so much, and I'm now welcome to any questions that has to be asked.
Thank you so much, ma'am. If anyone wants to ask questions, you can put it in the chat box or unmute yourself and ask. Any questions? Yes, doctor. You can ask your question.
Hello, can I audible? I am
Yes,
audible.
yes, doctor.
Dr. Aishwarya, it's a wonderful presentation and very eye-opening slides also, and your talk is very nice and very informative. Thanks and
Thank,
compliment for that.
thank you, sir.
Only
Thank you,
thing is
sir.
that I'm just asking whether it is a single or multiple. Our aim is that to clean the bacteria or bacteria byproduct from the canal. So if you are giving more time towards that cleaning and shaping and irrigation protocol you are following, then I think single sitting is much more convenient for the patient and for the clinician also, because in metros and other cities when you people are consulting for multiple times, it's actually endodontists are also in favor of doing single sitting because they have to visit multiple times to the clinic. And thing is that our aim is that to relieve the bacteria and bacteria byproduct from the canal. So if we will follow the proper irrigation, then I hope single sitting RCT is much more better than multiple sitting, I think. What is your view on that?
Okay. Thank you so much for your compliment as well as question, sir. So I definitely agree to what you are saying, but some patients do require multi-visit. That is one key note. And the second thing is always what happens in single visit when the number of irrigation, because irrigation plays one of the most important role when it comes to elimination of the bacteria from the root canal. The more the number of irrigation has been done, the lesser chances of post-operative pain. So I would always prefer to go for consultation once more rather than the patient calling me after 1 week and saying that I have finished, the case, and then I have to do a re RCT for my own case. And sometimes what happens is we are not able to predict what is the reason behind the patient's pain. And because the amount number of times we have done the irrigation, we will not be able to follow back whether our irrigation has been proper or not. So even though our irrigation is proper, the gram negative bacteria might need more of chlorhexidine irrigation rather than more of hypo irrigation. So in those cases, I definitely feel that not maybe more than three, but yes, definitely two-step endodontics can be done. But where we feel that a single visit is going to help, like a vital tooth, and if it is a single canal, and we have and there's no periapical infection, so in those cases we can go for single visit. Yes.
Thank you so much.
Thank you, sir. So I do see a few questions here. So this is from Doctor, which is asking what is the difference between open dressing and closed dressing, and which one is effective, ma'am? So this is very important. I would like to address the audience by saying that there is nothing called as an open dressing. Okay, the concept of open dressing has completely been eliminated from the literature. The reason being, I spoke so many times about how you place your cavity, how you place your intracanal medicament, right? In those cases, every time I have mentioned place a Teflon tape, I don't want any leaky margin, I don't want the cavity to be dislodged. So even though if you have an abscess case, do a proper biomechanical preparation, place an intracanal medicament, place a closed dressing, and call the patient after 24 hours. Remove your cotton cabot or your Teflon tape. Do a again one again round of irrigation, thorough irrigation, and then see for the prognosis of the treatment. Do not give open dressings. Open dressings always lead to more amount of reinfection. Next is from Dr. Mohammed. Hi, we need to go zero point 0.5 short of apex locator reading when it shows zero point 0.0 or be in the same reading itself. Okay, so sir, when it comes to using your apex locator, what I believe is the moment the apex locator shows beyond a red mark, you have to be in the zone of zero point 0.0, not zero point 0.5 short of the apex locator. The apex locator gives us the actual reading, which has to be taken zero point 0.0 only at that reading itself. So the next question is, should calcium hydroxide be placed for all teeth? Is hydrogen peroxide used to clean the canal? So definitely calcium hydroxide should not be placed for all teeth, because you should remember one thing: once anything placed in the canal cannot be removed completely, whether it is your GP solvents, whether it is your obturating material, whether it is your calcium hydroxide, you cannot eliminate 100% of the calcium hydroxide once it is placed in the canal, and then the integration between your sealer and the obturating material is going to come into picture, right? So never not a golden rule to place calcium hydroxide dressing in all the cases. Can I have a mute button? I think somebody's this thing is on, which is not helping me. Can you please help me with that?
Uh, yes, yes, ma'am.
Okay, fine. So I hope I was able to answer that. Not all calcium hydroxide need to be removed, to be placed in the canal. And somebody has now connected me with the same question, saying, what is the best way to remove the calcium hydroxide dressing from a canal? So the best way to place it, either you use your master GP cone inside the canal. So what you do is you place calcium hydroxide. You use a syringe. Nowadays we have so many pre-mixed calcium hydroxide tubes which are having, the syringe that can be placed inside the canal. So you can use that, and then you can use a Lentero spiral to place your calcium hydroxide, or you can use your master GP cone after you have seen the master GP cone in your radiographic apex. And in order to remove the entire calcium hydroxide, you need to do a very important proper irrigation, as well as you can use ultrasonic activation to remove the calcium hydroxide from the canal. The next is hydrogen peroxide. Yes, so I do often use chlorhexidine. I also use metrogel solutions when it comes to elimination of non-bacterial part on anaerobic condition of the bacteria from the root canal system. So you need to understand which clinical situations require which intracanal medicament. So the next question is, hi ma'am, how do you handle the patient expectations when their preferences for a single visit doesn't align with our clinical recommendation? So definitely you need to make the patient understand with the clinical recommendation. You need to make the patient understand that this is your tooth is having a periapical infection, there is changes in your periapical status. Obviously the patient will not able to understand all the scientific words that we'll be trying to say, but definitely the patient will be able to understand once you show the x-ray, once you show the amount of time that it took. Okay, so I am sure that the patient also helps us in understanding that yes, they do need more amount of time for healing as compared to a single visit, and you should plan this from before you begin your treatment. So, good evening, Dr. Tapas Bala, sir. I see your question here. Hi. Is there any indication of open dressing in case of short interval recall of patient who reports with acute endodontic condition? If yes, then please elaborate on it. If no, then how should we manage the flare up in case of a weeping canal? Okay, sir. Thank you so much for your question, sir. So, as far as your question is concerned, and as far as if you see the clinical situation, there is no condition called as open dressing. Okay, the entire concept of open dressing has stopped because we do not want any kind of reinfection happening in the canal. And I've also mentioned the role of saliva. The saliva itself has lot of other bacterial agents that can also cause reinfection cases happening. So we do not go for an open dressing, we always go for a closed dressing. Now, when it comes to weeping canals, the intracanal medicaments and the irrigation protocol helps us to reduce the chances of weeping canals happening within 24 hours also. So what we can do is we can irrigate the canal properly. We can do our biomechanical preparation. We can check if there is an open apex or if there are any missed canals or if there are any extra canals. Okay. Even after that, if we feel that there is weeping canal happening, we should place an intracanal medicament. Okay, because calcium hydroxide is so alkaline in nature that after 24 hours, most of the cases are reverted back. So then we should place a Teflon tape, we should de-occlude, and we should seal our tooth, and then definitely give antibiotic coverage and call the patient 24 hours after, just the next day, in order to see how well the tooth has moving towards the healing status and how well our prognosis of the treatment is helping. Thank you, sir. The next is cavities. When placed with gloves, it gets difficult to place it on tooth, but when with naked hand, it gets easy. Is there any way that it can be placed easily with gloves on? Yes, sir. Dr. Shashwat, we never place cavit with gloves. The first thing, we always place cavit with a plastic filling instrument, or the best is you can also use a ball burnisher. Okay, and place cavit like you're placing a composite material in different increments, right? So what you do is you take a small ball. First you place a Teflon tape, you take a small ball of your cavit, use a ball burnisher or use a plastic filling instrument and place it inside your canal chamber. Then take more amount of cavit and then place it. In that way, what happens is it is not going to get dislodged. Never use your gloves. The gloves are, you are using a contaminated gloves which you have been using to touch so many instruments around your canal, around while you're working space. So never use gloves. You have to use your instruments. Your instruments are made for that. Use a plastic filling, use a ball burnisher, or use any other instrument which will help you to pack the cavity inside the canal. Cotton dipped with formocrosol can be placed before placing cavit, ma'am. There is no concept of placing formocrosol, ma'am, inside the canal nowadays. We are going to, what is the role of formocrosol? We do not want to devitalize our pulp. The entire concept is to now do the axis opening, remove the pulpal remnant, remove the debris, do a biomechanical preparation. That is why I told you what are the different steps to be carried around in a single visit. You have to do irrigation, you have to complete your BMP, and then you have to seal the canal. No placing of formicrosol. If you feel that, it happens when you're doing a post graduation or a graduation, there are a lot number of patients and you're not able to handle, right? At least use your rotary instrument up to 20% or 25, 4%. Remove the maximum debris that you can, and then only move towards placing a cotton cavit. Formicrosol has no role. Hello, even if there is swelling or active pus discharge, no open dressing. Cause it if closed dressing is given, patients come back with severe pain. Yes, Dr. Devanshi, if you look back at the literature, there are so many people debating on this. You understand one thing: why is the patient coming back with pain? Is the patient coming back with pain because you gave a open or a closed dressing? No. The patient came back with pain because there is some kind of pulpal remnant still inside the canal. There is some kind of infection still inside the canal. How is your open and closed dressing going to help? Only the open dressing is going to increase more chances of micro leakage and nano leakage from the saliva and all the food products that the patient is going to eat. Okay, you can de-occlude so that the pressure reduces. Okay, you cannot you it's okay, you cannot pack the complete thing with tight seal. You can place a small amount of Teflon, place a small amount of cavit. Do not do a complete coronal seal and then call the patient the next day. Okay, and if you do a proper biomechanical preparation and irrigation And if there is a pus discharge, you need to give a triple antibiotic paste or you need to give an antibiotic coverage, and then definitely call the patient after 24 hours. Do not go for open dressings. You might be seeing so many people talking about open dressings and closed dressing. In my next webinar, I will definitely take up this topic of open versus closed dressing. Can post endo restoration done on same day? Yes, sir. In single visit, you can do, but definitely the best is to avoid doing a post endo restoration on the single day. There are again debates regarding this, because if you're not placing your cavity properly, then your post endo restoration plays a very important role. If you feel that the patient is going to go back because of some important reasons, and the patient is going to come back after 15 days or maybe more than a week, then go for a GIC restoration. Instead of going for a temporary cavity restoration, go for a GIC restoration. And what about RCT in pregnant women? Can X-ray be taken? So these are a lot of questions which is just coming for random questions for in relation to root canal treatment. Today's topic is single versus multiple visit. X-ray to be taken in pregnant woman has to be checked on which trimester the patient is, and according to that it has to be decided. Thank you so much. Sure, Dr. Devanshi, thank you so much.
Ma'am, we have a question from Dr. Mohabbat. Your view on using dual cure resin cement in post-endo restoration, doc?
Yeah, so when it comes to post-operative, post-endodontic restoration, you can also go for rebond fiber posts, or you can also go for dual cure resin cements. They are very good. Dual cure resin cements by Ivoclar as well as by Colteen. When you have DME, that is deep marginal elevations, in those cases, definitely we can use dual cure resin cement. It gives much more effective results, and then followed by a crown cementation.
I think we are done with question and answer session.
Yes.
That brings us to the end of today's session. A big thank you to Dr. Aishwarya Arya for your time and expertise, and all the attendees and for participation. Do follow us on Instagram for more further updates. Until next time, stay curious and stay passionate. This is Janvi signing off.